the education policy in Australia. And what you see in the streets of Melbourne and Sydney, you find a lot of international students from India, from Singapore, from Hong Kong, from China. They were part of that. They were part of that skilled immigrant program, which was brought through demonstration of the English language competencies, gaining or acquiring a degree here in Australia, which would then subsequently ensure a permanent residency pathway. So that was the second stream of migration to this country. Um, the more recent stream that we're seeing now with the recent population plan for regional Australia, which was developed not long ago by the Regional Australia Institute, and more so since 2015, has been that we have a regional settlement program. That is, we're offering international students additional bonus points to migrate regionally and do their degrees regionally. So that would feed into the regional population plan. We're also doing this in terms of the refugee settlement plan. So you've got Syrians who, were settled in Armidale and elsewhere. Um, and I guess in some ways we got to reflect on this, that this was to strengthen the national population plan. I guess there were some sites that I'd embedded in the map, and I'm assuming that these will slowly populate on the map. But thinking about the previous slide was more around the policy of settlement and how there are these three sort of streams or strands that bring multicultural communities together on different visa conditions. You've got the refugee cohort, you've got the skilled migrant cohort tied to the international student cohort, and you now have a regional migration program tied to immigrants, which they get extra points to migrate to regional Australia. So this map is actually demonstrates some of the sites that I've, or in fact, majority of the sites that I have personally visited as part of the former project that I worked on, assisting Professor Jock Collins and Professor Brankas Krivokapic-Skoko. And the project was looking at new immigrants in Australian agriculture. And I worked on this project for 3 years. And so I was the lucky person traveling around Australia. And I had the opportunity to go up North Cairns looking at, and I actually interviewed a refugee man who arrived in Australia with $5, but now has a 50-acre banana plantation. So you've got Pacific seasonal workers as well in Cairns, alongside Innisfail, where some of the refugee settlement has taken place. And then you've got Indian Samoan settlement across Camden, Griffith, Euston, Robinwell, Neil, Mildura, Naracoorte, and you've got some on the outskirts of Perth and up in Carnarvon. Now, the point I wanted to make with this map is you can see the tyranny of distances. You can see what Australia is laid out like. It's this country. Some of these sort of rural towns, they're 3 to 4 hours away from the nearest international airport. And so I can see why the government has laid out an incentive to both migrants and refugees to say, look, if you can go and settle in a regional area, you'll get more points. But one of the things that that drew me to this conversation around telehealth was to think about the services that perhaps these communities might require. So if Ben, you don't mind, we move on to the next slide where we can then tie in the map to some of the issues. So I've just mentioned from the previous map, in a number of these sites, it's evident the tyranny of distances, but additionally also around not very well serviced hospital zones. And I live in Darwin, which is serviced for the moment. But RDH really is our only public hospital. We do have a national critical trauma care center, but in terms of if there's a COVID outbreak here and how we are likely to manage it. But the reality is that unlike somewhere like Sydney or Melbourne, we just do not have that same level of health infrastructure. As a result of some of these reflexive policy narratives, we now need to bring that together to think about telehealth then is the number one service that perhaps these community groups depend on. And additionally, we also know that some of these telehealth providers also depend on interpreters. So it really is a complex and essential service. So telehealth, therefore, then should be a policy priority in general when thinking about equity in health, and more so in the case of vulnerable refugees and migrants. And I guess Ben will now seamlessly walk you through the telehealth aspect of the presentation. And I look forward to your questions. Thank you.
Thanks heaps, Devaki. That was really great. Really fascinating to get your perspective on that experience of rural and regional Australia and migration. I think it's a perspective that we, in my opinion, really hear about. And yeah, it's a great chance during this webinar to talk about some of the issues that you raise. So before I begin, I'd like to also acknowledge and pay respect to the traditional owners of the land on which I'm presenting from here today, the Ngunnawal peoples. And it's upon their ancestral lands that I am talking with you today. So I'd like to also begin by acknowledging that much of what I'll be presenting here today is based on a recently published article by my co-authors, Dr. Devaki Manani and Professor Gemma Carey, and a knowledge translation article that we developed with Mary Ann Geronimo and soon to be published in Fecker's national magazine, Australian Mosaic. I'd also like to acknowledge that the many people living or working in Footscray and Melbourne's West who helped me start this work many years ago. Those people include Tony Lin Win, Bar Salofu, Puriat Babajan, Godoffer, Helen Ball and Dan Harris, and many others who are part of or worked closely with refugee and migrant background communities. So as Devaki suggested earlier, today I'm going to share with you an overview of what the evidence tells us about opportunities and barriers in the use of telehealth in Australia for better supporting the needs of people from refugee and migrant backgrounds. I'll be referring to legislative changes, experiences with language, culture and healthcare technology specifically, and how the broader conditions of life shape access to telehealth. So I'm hoping that by turning to the evidence and then learning from my fellow panelists, and of course you all here today, that we're able to think about and possibly determine some viable options going forward that may actually help to reduce some of the barriers to telehealth and make it more inclusive for the long term. So refugees and migrants have experienced major social, economic, wellbeing and health issues associated with COVID-19. Initial reporting suggests that the issues may have become worse due to barriers in accessing culturally and linguistically appropriate medical care and information, both offline and online. So for example, many refugees have been prevented from being tested for COVID-19 due to a lack of appropriate information and concern about being reported to government and visa cancellation, detention or deportation. There's been an increase in reports of refugees with a mental health condition posing a serious risk to their safety, including sadly things like suicide and self-harm. International students have reported experiences of racism and difficulty finding appropriate support for managing the pressures associated with study and financial instability. We also know that elderly migrants have been much more vulnerable to health issues during COVID-19. Elderly migrants can lose the ability to use English and often prefer communicating in their first language, which can make understanding information about COVID-19 difficult and of course increase the risk of infection. So a major issue has been the fact that Medicare has not been available to refugees who have temporary visas, meaning it's been much harder to pay for counselling, medication and other health support, increasing the stress and the risk of health problems, particularly now with COVID-19. So as many of you may already be aware, in March of 2020, the Australian federal government made temporary changes to the Medicare benefit schedule to help people use telehealth for accessing medical care and advice, while also reducing the risk of infection from COVID-19. So the changes included things like adding of video conferencing and telephone items for a range of services, from things like standard general practitioner and nurse practitioner attendances through to health assessments, chronic disease management, pregnancy support, mental health, and many others. So generally, telehealth refers to the use of phones, the internet, video software platforms like Zoom and Skype to help people communicate over a distance with a doctor or health professional. And as Devaki mentioned earlier, telehealth has great potential for reaching people in rural and regional areas of Australia. So the technology allows access to medical care and advice from the comfort of home or a patient's preferred location, including when access to a medical clinic is difficult. And research has found that the changes to Medicare for telehealth, so the changes that the government made in March 2020, were associated with a major increase in the use of telehealth by the general Australian population and helped to reduce the risk of infection. But despite the promising uptake of telehealth, evidence also suggests that the legislative changes did not address the health issues and barriers facing many refugees and migrants. One of the most significant barriers to access and use of telehealth is Medicare eligibility. So many people of refugee and migrant backgrounds who have temporary visas are not eligible for Medicare. For those who have temporary visas, they generally cannot access subsidised healthcare through Medicare, including telehealth. What this also means is that those without Medicare, including refugees and migrants on temporary visas, could not access subsidised telehealth when the government made the changes. There are many other legislative and other barriers too. The My Health Records Act and its guidelines, which govern the use of telehealth and other online platforms, they don't provide direction on using appropriately qualified health professionals who are able to deliver culturally and linguistically inclusive medical care and advice to refugees and migrants. The Act also doesn't recommend the use of accredited translation for health needs. So without that appropriate legislative support, it's much harder to ensure that telehealth options incorporate the use of things like preferred languages in medical appointments. But beyond legislative barriers, telehealth also has some issues too. It can't provide physical examinations. There have been difficulties in obtaining prescriptions and pathology results. Some people may be hesitant to use online platforms due to their experiences of isolation, trauma, stigma, a lack of social support, and not enough linguistically and culturally appropriate information about the services themselves in telehealth, as well as the services. So poor quality internet, a lack of affordable internet, and relatively low levels of understanding and skills in using more advanced technology is an issue for some groups too, including those who are elderly. So really that combination of legislative and other barriers represent a major problem for greater use of telehealth in Australia, which is based on the evidence is problematic because, as we know, Australia is a country which has the third highest proportion of residents born overseas of the OECD countries, and where over 1/5 of Australians speak a language other than English at home. So based on the evidence that I've shared with you about the barriers to telehealth, my colleagues and I have identified 5 major opportunities to address and hopefully reduce those barriers to telehealth. The first opportunity is to extend and evaluate access to Medicare for temporary visa holders. By extending access, many refugees and migrants are likely to be able to access more affordable healthcare in general, including telehealth. The second is to amend the My Health Records Act to recommend the use of appropriately qualified health professionals for refugees and migrants, and also accredited translators in telehealth. Those changes can help to strengthen the health system to better support and reflect the needs of the Australian population, both now and the long term. Thirdly, extending and evaluating access to government-funded social safety net support for those on temporary visas to help address some of those economic, education, and other social determinants of health is likely to help general access to telehealth. The fourth option is to make further changes to Medicare. So by adding and evaluating specific Medicare items for people of refugee and migrant backgrounds when using telehealth, and those focused on health issues associated with migration and settlement, could help to develop more appropriate medical care and information and support greater investment in the healthcare workforce in the long term, and obviously to deal with the current situation with COVID. And finally, I just want to emphasise that despite the fact that my colleagues and I have brought this evidence together today, there's still a lot that we don't know. So research and evaluation can help to better establish understanding of the experiences of refugees and migrants in using telehealth, and other forms of information technology for health communication online, and can help to identify what approaches may work best. Past studies, while quite limited, do suggest that things like video conferencing and community-based approaches to use of mobile phones do show potential for helping guide future work on telehealth in Australia. So I'd like to end my overview by noting that despite the opportunities I've identified here, the barriers to telehealth based on the evidence can be significant. For those living in rural and regional areas, the barriers may be even more challenging given the combination of less healthcare services in general, as Devaki mentioned earlier, as well as difficulty in using technology easily and the other challenges as part of daily life. So achievable and practical steps in the short term with a view to long-term change might be the best way forward given such barriers. So, for example, advocacy for making sure that the Australian government's national stand down and evaluation measures gather information specifically about the impacts of telehealth and its barriers in relation to language and so on may help build a stronger evidence base. Increasing awareness of existing evidence-based options for interpreters and translated information when using technology for medical care and information could really help too. So things like the Health Translations Directory, the Translating Interpreting Service, and the recently established Multilingual Information Access Platform. So health and other government agencies could promote these platforms and could promote them more and find ways to embed them in standard policy and operating procedures. And community radio stations, community associations, and representative bodies could also play a role in that promotion. But given such barriers to helping make telehealth more inclusive and the recent increase in COVID-19 cases across the country, I'd like to encourage Marianne, Apajok, Devaki, Jem, and you all who have come here today to reflect on what else might help going forward, whether the practical steps I've noted are useful, and how else we might expand the evidence base, or what else might be a priority in making healthcare and technology more inclusive as we continue to deal with the pandemic. And that concludes my overview. So I think I will hand over to Jem now, if that's okay.
Yes, and we had a slight recording hiccup. So for all of the people who listen to this recording later on, I'm just going to do a really quick reintroduction of the panel. So on the panel, we have Devaki Manani from Charles Sturt University. Devaki has worked with an incredible range of diverse communities in Australia. We have Marianne Geronimo, who is the Director of Policy at FECA, and her expertise are in how policy systems are impacting diverse communities. We have Apachok Bier, who is a community facilitator at Create Foundation. She was born in a refugee camp in Kenya, and she works to advocate for gender equity in youth participation. And we have Ben O'Mara, who is from Swinburne University and has been working in health communication with linguistically diverse communities across Australia. And I am Gemma Carey. I am the National Research Director for the CSI Network, and I'm based at UNSW. Sorry for those who have had to do that twice now. Okay, so we're going to go to panel discussion. And Rhonda, I might get you to close the slides. The impetus for this webinar was a piece of research that Devaki, Ben, and I led, which looked at the ways that governments and other groups should and could be communicating with diverse communities in Australia, remembering that we are one of the most linguistically and culturally diverse nations in the world. The work mapped out barriers for migrants and refugees, as Ben talked through, accessing basic health services, from Medicare through to how we actually engage and how are we working with different communities during COVID, a time where we have needed to get health messages out very quickly and very effectively. And I think that we would probably all be in agreement that we haven't achieved that. One of the other things that this work challenged us to think about is the ways in which things that many of us, perhaps middle-class white Australians like myself, thought were great policies to emerge out of COVID, like Medicare access to telehealth, aren't actually accessible to an awful lot of people in Australia when you look across the board. Now, with most of our nation in lockdown, I'm sorry to do this, but I do feel like I need to hit the panel with the first question about COVID. So right now, recognising that the answer to this question is going to be different whether you live in New South Wales in an urban environment, or as Devaki's beautiful map showed, spread out, you know, in the Northern Territory and Cairns, you know, and remote areas in Australia. My first question to the panel is, what are the current challenges for migrants and refugees? Devaki, you're located in the NT, you've travelled around the country. I think a lot of people in Australia think about migrant communities as being kind of clustered in Sydney and Melbourne and urban centres. So if I could start with you and your answer to this, and then Marianne, I'm going to jump to you for a bit of an assessment of what's kind of going on in our major cities. So over to you, Devaki.
Thank you, Gemma, for that question. And thank you, Ben, for revisiting some of those issues around, particularly around temporary visas. So I want to tie that conversation into Gemma's question. One of the key policies in Australia around settlement for both migrants and refugees is that the current policy is that the permanent resident pathways are sort of fast-tracked or enhanced, or you get additional points if you reside in a regional area. And that is, so you know, like when I migrated to Australia, I was in Melbourne. I got 60 points as a social worker to migrate to Australia, but I was in Melbourne. But it's not the same anymore. So people are forced, because of the policy, because it's tied to the regional population plan, people are forced to live regionally to demonstrate that they've lived in a regional town for 5 years. So that would fast track their permanent residency, and then they become citizens. What normally happens is a number of people leave, even though living in regional areas is really amazing and it's beautiful and it's pitched to you that, you know, there's no traffic and all of that, but there are no services. This is a reality. There are no GPs that stay longer than probably 2 years. They're moving constantly. So I think the challenges for migrants and refugees in general, there are many, and that we hear in the media and we watch on the news, and there's, you know, a vast array of difficulties. However, more specifically, these are compounded by these visa conditions and these pathways to the desire for achieving permanent residency and citizenship that are increasingly tied to living in regional areas, which I think can compound conundrums. What we could do is get citizen migrant people to migrate and give them job opportunities and employment and say, well, you should move, which what I did. I'm a citizen migrant person who chose to live regionally, which is different to getting vulnerable people without those continuous visa conditions, but that exclude them from issues like Medicare, services like Medicare and other opportunities, which full citizens get nevertheless, you know what I mean? So I think that's the key challenge, is the disconnect between the policy, the settlement, and access to Medicare, and then its impact through not having sufficient funding into services like telehealth. So
thanks,
yeah,
Devaki.
thank you.
And other panel members feel free to jump in as well. But Marianne, what's your sense from a more kind of urban perspective?
Yes, it's very interesting because, you know, there's not much difference in terms of what's happening in the rural regional areas and what's happening in urban areas in terms of, you know, access and equity issue in health. Because, you know, when you use telehealth, it's sort of like a very simple problem, but even when you dial case support, the first person who gets to you speaking in English. So it doesn't make sense. That's the first barrier that people would say. It doesn't matter whether you're in an urban area or rural area, it's the same problem. How do you then address that? And this is the kind of issue that we've been struggling since COVID happened, because people want everybody to have access to the supports. And there is, in fact, some multilingual COVID support systems that were being tested, especially among the older population. But even that has not been working well in terms of, you know, not given the support that it needs for the community to understand how that works. So given that kind of issue, so the difference is you have a system, but you created a system that does not really integrate with the rest of the continuum of care. So you have a telehealth system that sort of exists in a vacuum and does not make a very implicit connection with all the other support systems that are in fact available in the community. What we've been seeing, in fact, is that when we see a very disconnected kind of system, it really lacks an understanding that there is a need for a better cultural framework when people are designing these kinds of system. Because for people, whether they are in the urban area or in the rural area, there is a more complicated way of going about seeking health services or seeking, help in general in terms of social care. So what we are seeing is that you have telehealth, you have navigation system that's separate for aged care and health care and disability care. But just the same, they all go through some telehealth or TIS, telephone-based kind of technology system. And what we are kind of concerned at the moment is that there's a lot of push for people to go on. We understand, the requirements because there's a COVID situation, but even before COVID happened, there's a lot of push for people to use telehealth. But as Devaki mentioned, we have not yet put in the foundations for people to understand how that works and how they can be supported to use that system. People are coming in from different backgrounds, as Devaki mentioned. And so the very basic understanding of even, health literacy is not there. So for us to understand how the health system works, there has got to be a more upstream kind of, intervention for the community to support people to understand what telehealth could do for them and how they can in fact access telehealth.
I think your emphasis on from the first point of design, we have to get it right, and then it all flows through. I spent a lot of time working on the NDIS. It's the same sort of thing where an interpreter can't come in until you're already on the NDIS. But to get on the NDIS, you had to go through phone and English written paperwork. So we see the same thing across so many different policy areas. One of the things that I'm really conscious of is the intersectionality is very important when we're talking about these kind of issues. So, we have communities like we've just talked about who are disadvantaged by the design of systems that we are building. But then we have other individuals that are embedded in those communities who are more disadvantaged again in particular ways. So I wanted to ask Apachok about how she sees the key health issues for women and refugee families right now in Australia.
Thank you, Gemma. Before speaking, I'd like to acknowledge the traditional custodians on the land which I'm speaking to you guys from, which is the Aranda Nation here in Alice Springs. I think one of the biggest challenges coming out of COVID at the moment, especially for refugee migrant communities and also women, is mental health. I think with their husbands working long hours, especially in these rural settings where they work long hours, 10 to 12-hour days, and then they're home with the kids in lockdown. And we've been raised in such a community where we lack a collective society. So we like to come together at a park or a community hall and sit down and have a chat. And unknowingly, that is supporting our mental health. But through COVID, where you are isolated and you're at home and you're not having those avenues to go out and speak, and you're not aware of either the signs or the triggers of mental health, red flags coming up, then that is concerning. And you just go into this place of self-isolation and not knowing who to go to or where to go to for that support. And a lot of women in our community are facing that right now. And on another level, with the young people in our community, we are more inclined to reach out for support, but a lot of people have been finding challenges with reaching out and calling these mainstream mental health support services, where they would make a phone call and talk about what they're struggling with. And on the other side, the person who's meant to be counseling them and supporting them with the mental health starts to cry because they are overwhelmed with what they're hearing. So how is that? That's not adequate. Both sides need to be trained in trauma-informed practice as well as culturally competent practice. So we are not further re-traumatizing people who are actually willing to reach out. And then on the other end, we need to be looking at how we can better support refugee and migrant communities to break down these stigmas of mental health, to see these red flags and to be able to reach out for support. And that support will probably start within their own communities before reaching out to health professionals. So how can we be equipping the communities to be able to support the members within their own communities and the challenges that they're facing? Thanks, Gemma.
Just to add to what Apachok was sharing, Gemma, one of the things that we've been hearing from the community is that, yes, there's a telehealth platform to help people, but for women who are in domestic violence situation, calling from your own home where the perpetrator is there, how does it even work? So these are the things that are not sorted out. And given the COVID situation, it's very challenging to go about that. And so Apachok was saying, there is a role for the community and we have to give that role and support the community to do that.
And from where you sit, what would be the best way to support the community to do that?
So this is something that has changed drastically or dramatically over the few years. I think in the very early years of multiculturalism in Australia, there's a fair bit of support that's given to communities in building, organizing and developing their capacities to, encourage people to be connected, not to be isolated. Of course, I'm talking about a situation where COVID-19 does not exist. But you see, we have veered so much far away from that kind of, structure that when COVID came, it really showed how much, limitation there is because small communities, for example, are not supported before COVID came, and now they're scrambling on how to support each other. So these kinds of interventions we need to continuously do because people will always have groups, even within well-established, multicultural communities, there will be people who are very much in a vulnerable state and needing support. And there are roles for community organizations to continuously do their work, to do outreach, to develop people's capacity and understanding on how to even access all these services, health, disability, social care, all these things need to be, facilitated by people in the community.
Thanks, Marianne. Abhishek, did you want to add anything about how, your thoughts on how on-the-ground support could be supported better right now?
Yes, definitely. I think finding the key members within communities, they don't have to be traditional leaders. They could be focal points within communities and training them up to be able to better support the community members and being intentional about ensuring that in this group that you're training up, making sure that there's women in that group, making sure that there's young people in that group, because at the end of the day, women speak better to women, young people speak better to young people, and sharing it across the panel like that. Because traditional leaders in our communities generally tend to be men, and sometimes that information doesn't filter down. So if we're finding key members within the community to be sharing that information would be essential.
I'm going to go to the last question for the panel and we will open up, but there's 2 points out of what that discussion covered that I think are really important just to highlight. The first was your point, Abhishek, was trauma-informed practice. If we don't have trauma-informed practice on the people answering the phones, that seems like a pretty big skill intervention to me that sits in the hands of governments. The other one is that, again, it comes back to making sure our systems are not top-down designed, that we need to have more embeddedness in communities to understand communities better in order to build systems that actually work for your communities, and also support community leaders in place rather than necessarily build on top of as well. So I'm going to go third question, which was, we have had so much policy change in the last 18 months. And in fact, there has been so much, it's hard to keep up with jurisdictional differences at any one point in time. So keeping that in mind. But of those changes, I'm just wondering, what are some of the big ticket items that have been helpful and the big ticket items that have been harmful for different communities in Australia, recognizing that, there is a lot of diversity there. So I'm just going to pass to Marianne and then Devaki and then Ben for that one.
I guess the policy changes are really major in terms of, how people has changed their behavior or not changing their behavior, is that there's a lot of focus on individual, choice and control. You could see that, very, very strongly within the aged care system, for example. But if you are looking at people from CALD backgrounds, those who are linguistically diverse, choice and control, if you're a new migrant, if you're coming from refugee background, trauma background, what is choice and control? It has to be, for you to even make that choice, it has to come from, a sense of empowering, information or even an empowering environment to make a good choice and to be in control of the choices that you are making. So the policy directions that we have been taking, the government has been taking so far, is really in that direction. And it does not recognize that people are in vulnerable situation and are not yet able to be in that stream of individualized choice and control. And for some groups of people, individual, focus is just not possible, because in some cultures, there is this complexity of, having a group decision making. It's culturally, that's how it is. And even decision making in some, groups of people is not only done by this person himself, but sometimes they have to have someone who is a substitute decision maker just because they trust this person. So there are these complexities that policies does not seem to understand. And so people sort of fall, behind that policy development, and they have to seek help. In some areas there is help, but also, the navigators have a very big role in this area for people to understand the choice and that they have to make. But this is not also a very well-developed and well-supported area of service, that they have, they have become very disjointed. If you're an older person, then you just have to seek navigator for old age care services. Disability, then you have, so these are, but you can be an older person with a disability, and with a lot of social care issues. So there is that, a difficulty of understanding the differences in all these things.
Thanks, Marianne. Devaki, did you have any thoughts you'd like to add on big ticket items that have been helpful or harmful?
So just following on from Marianne's point about choice and control, and Apajok's point about leadership and men, I just wanted to sort of tease out that point a little bit more, because when we all get together as academics or people in the industry, and we come together and we talk about these issues, what I've been doing since COVID began, and that's something you might be interested in doing, is I've been looking at all the leadership. Say, for example, and I particularly do tease this out for multicultural ministers who have the multicultural portfolio. And I look at their leadership, their multicultural advisory council, or like if you look at their every parliamentarian has a multicultural advisory council. And if you look at Canberra, for example, Alex Hawke, he's the MP for the multicultural portfolio. And that's what I've been doing. I've been looking at and if you look at his advisory council, 75% or more are all men from multicultural backgrounds. Some of them who I know of their dubious practices, but they are on their advisory council. So what we're all up against is a challenge where our voice, the voice of the civil society, needs to be heard and reflected at that Multicultural Advisory Council. And I'm only picking and teasing that thread from Apajok and Marianne, your conscious observation around decision making. Sorry, over to you, Gemma.
Thank you. I'm sorry, Ben, to skip over you, but if we don't move to the questions in the chat, we won't get to questions in the chat, and I think that people have got some good ones. So I'm just going to go over to what have been put in the Q&A, but please add more. People have been asking questions throughout. One of the questions that was asked, I'm just going to put this to the whole panel. Do you know whether interpreters that you're engaging have been trained or qualified to do the work, not just goodwill bilinguals without any health literacy? That might be a question for Ben or for
Ben, you should answer that question.
I think that can be an issue in certain situations and in some communities. I do know that there are important agencies that share information about the importance of having accredited translators and interpreters. I'm thinking of NATI, I'm thinking of the Centre for Cultural Ethnicity and Health, I'm thinking of the New South Wales Department of Multicultural Health. I think that in some situations it may be quite difficult and there may not be any other options available. It may not be great and it's not, not effective, but in some situations, due to a lack of broader social government support for promoting and better linking to accredited translation, that may occur, having those without the appropriate training and so on. I guess I just want to flag though that is an area where significant understanding within what I call the broader mainstream systems of governance, that's an area where there could be very targeted and effective change to increase understanding of the importance of investing in accredited high quality translation and of reducing stress on communities who are placed unnecessarily into situations where they're forced to make these decisions. And I actually think, sorry to rabbit on about it, but just listening to Apajok and Marianne reflect actually quite specifically about the communal experience of health. And I'm just wondering if there's something there too that's linked to translation and interpreting and better understanding the communal approach to health. And linked to that, there has been over many years, there have been studies that have shown great projects involving and driven by communities and community members. Apajok talked a lot about how we increase understanding and skill within communities and go from there. I think one of the biggest issues is that whether it's that link between great work and outcomes achieved by communities isn't being linked into policy development, into system change, into understanding that, hey, there's a communal approach to health. There's also, and as part of that, how does translation fit into that? And making the systems change as a result to better support high quality translation and a communal understanding of health. And I think that's a big gap. And I think that's something we could do a lot of work on.
Ben, while I have you, got another question for you. The study showed the barriers. Did any benefits come out of the reviews and work that we have done?
I can share these studies a bit later, but there's one key study that came out from memory 2015. It was in Melbourne. From memory, it was in a hospital setting where refugees and clinicians used video conferencing to better support refugees, and there's some evidence of effectiveness there. I just want to highlight though that it was a small study. It was in one place. It doesn't represent the experiences of all communities across Australia.
All the academic caveats.
Yeah, and it was in a very I should say supported setting, like in a health centre. So that I need to go back and read the article, but from memory, that centre was likely to have had good access to video, good access to.
It might be worth. I know it's a troll, but sorry, I can't see who asked that question. It might be worth having a look in the reference list of the articles that got posted to see the individual studies and what were, where there were some good outcomes.
I would like to explain very quickly, if I can. There was a study that involved community members of Sudanese background in Melbourne, where community members were supported through funded vouchers for mobile phones to get training in psychosocial health. as a way of better getting building community capacity to better link people to services, including health. I think that's, so the use of mobile phones, I just want to flag there, and supporting community members and having a community-driven approach. There's some evidence there to suggest that can help. Thanks, Ben.
I've got a question for you, Marianne, which was, sorry, technology. You said that things have changed dramatically, so that communities are less well supported. And the question is, what's changed and why? If you can do that in under 3 minutes, that would be amazing.
I think there has been some changes in terms of, actual resources that are being allocated for community building and community development interventions. I think in the last, early stages of multiculturalism, there is real and substantial support for community development work. But nowadays, community development work is no longer as recognized as important. And it has been something that I think in the health stream as well, not very much recognized, despite our, constant, statements saying we understand the social determinants of health. But you see, how do you even respond to that if you don't start with real community development work? But can I just, that's my answer to that question, but I'd like to add to what Ben has said earlier, because there are, in fact, a lot of promising things that are happening, good things that are happening. For example, in the space of translation, FECA has been very much involved on the COVID-19, interventions for CALD communities. We have, in fact, worked very closely with the department in terms of setting up the CALD COVID-19 Health Advisory Group. And what has come out of that initiative is, for example, in a few weeks' time, we'll be testing out a community review panel. And the review panel is really to understand how we could develop the community's expertise of their language so that they could support translations, or even maybe in the future, a telehealth service that's really, on point and, salient and relevant to people who are speaking to them in their language. And it really starts with the basic information that people are developing. And so we are trying to develop the capacity of communities of languages to have that, not of professionals, but people in the community who will be the end users of those information. So that's coming in the next few weeks.
Great to hear. Thank you, Marianne. I'm going to go to the absolute final question and then pass back to Rhonda. So Jackie has asked if anyone is aware of any projects, either independent or funded by government, that are evaluating the telehealth models and their use by CALD populations. That might be a Ben, Mary, Devaki question. No one? Anyone know of any? I don't know of any.
No, I don't know of any. And I think that's a Marianne and Ben question. And that was a discussion we were actually having before. So
did you want to jump in, Marianne? Are you happy for me to have a go? Yeah. And I'm conscious too that Marianne has read some other work that I've worked on with Jem and Devaki, but I just want to say that Jem and Devaki and I reviewed quite a lot of evidence really up to the state of play around start of 2021. When we wrote an article for the International Journal of Health Policy and Management, where we looked at the evidence around telehealth and effectiveness and people of refugee and migrant backgrounds. As part of that, we looked at what evaluation projects were occurring in Australia right now. When looking at that evidence, we did not at that time identify that there were any major projects evaluating the effectiveness of telehealth. That's why Jem and Devaki and I put forward an option in terms of trying to make sure that the national stand-down measures incorporate some sort of evaluation around the effectiveness of telehealth in relation to language and culture. So short answer, no, and most likely not, but I think addressing that area evaluation in the stand-down measures, I think could be beneficial.
That's our last question. My only comment on top of that to wrap up is to say that I think that evaluation and funding of good evaluation is something that is falling away generally and is really, really important, because otherwise we just do stuff and we never capture whether or not it worked and changes. And CSI is an evaluation expert. We are doing things like launching our Amplify social impact platform, which is aimed at building the capacity of organisations in the community sector to evaluate their work without having to have significant government funding. So you can contact us about that if you want to. I'm going to pass back to Rhonda to wrap up for the session. Thank you everyone for coming. And if people had to leave early or came late, I saw people coming in late, this will be available online as a recording, and so you can go back and visit parts of it, and you can access the resources as well. Rhonda, is there anything that you want to say before we shut down?
I just want to thank you all on behalf of the audience members, you, Gemma, and also all of the panelists. It was really interesting. I certainly learned a lot. I'm sure others did as well. So thank you very much. We'll be sending the recording along with a few resources. I might get a few from the panelists, and I'll also check out any of the questions that we didn't answer. We might be able to put those in the follow-up email as well. So you'll hear from me via CSI, probably later this week or early next. And I encourage you to visit impact2021.online for more info about our webinar series. Thanks so much, everyone. We'll wrap up there.
Please tweet and Facebook and LinkedIn and all those things about how useful you found this and how you think people should listen to the recording and come along to the next one. All the platforms.
Thanks, Gem. Okay, bye, everyone.
See everyone.
See ya.